First one. Good morning and good evenings. I am P.Y. Cho and my colleagues, Dr. Junior too. We both will moderate this webinar. And welcome to ICC again. Professor WooYeol Baek finished his residency training in Severance Hospital, Yonsei University in Seoul and Korea. Currently, he was appointed as an assistant professor in Department of Plastic and Reconstructive Surgery and won his PhD degree in Yonsei University. Professor Baek is a clinical interest focused on the migraine surgery, TMJ surgery, microsurgery, or for the head and neck reconstruction and the craniofacial surgery, aesthetic surgery as well. And his research focused on the tissue engineering, polymer, and the collagen scaffold. Professor Baek has published 20 more SCI papers in the field of breast reconstruction, craniofacial surgery, sarcoma reconstruction, and so on. Today, we are so honored to have Professor WooYeol Baek online in ICC to give us these lectures entitled with the whole cranial remodeling by distraction method for patients with the craniosynostosis, bidirectional distraction for craniosynostosis, and three well-known international panelists, Professor Ike Tamada from Tokyo Metropolitan Children's Medical Center, and Professor Tinchen Lu from Chang Memorial Hospital, and Professor Roberto Flores from NYU in the panel discussion. So let's welcome Professor Baek. Please, Professor.
Thank you for introducing me. It's very honored to present this session. Today, my topic is surgical method for the craniosynostosis. I am now in Yonsei University in Korea. I'm the assistant professor. And today, I want to show you the method of correction both sides of a craniosynostosis through the bidirectional distraction. You already know in pediatric age, there are various cranial sutures in the normally present, but in a lot of region, there are early closures occur earlier than normal. It results as the diagnosis of the craniosynostosis. The earlier fusion of a cranial suture lead to dysmorphic of a cranial shape, and various surgical technique are now doing by a lot of surgeons alter the shape of a timing of a suture closure. And today I'll discussing only a distraction method. In generally, correcting the craniosynostosis is commonly a correction only on one side at one time, the frontal advancement or posterior distraction. But like this method, they only correction the volume, but they do not correct asymmetric or frontal width. And also, there are posterior cranial vault distraction. They are only expansion the volume only. They do not correction the asymmetric or skull width. Like this case, they do the surgery by prone position, but in pediatric patient, it's very the prone position is not good for the pediatric patient. And also, if there are some bleeding on the posterior area, it's very hard to stop the bleeding. Initially, our institution, we have a pioneer, the Dr. Kim Young-wook. He do this cranial district surgery almost 20 years with Dr. Shim Gyun. He's a neurosurgeon. And this year, Professor Kim has for the retirement, and I have to the honor to continue this legacy working with Dr. Shim Gyun. In 15 years, there are 198 cases. You already see like this graph. The unique corona case is the most case in craniosynostosis. The surgical age is from the 5 months to 3 years average. And today, I briefly describe our method and planning and surgical method. This is a unilambdoidal suture craniosynostosis case, but you can see that this CT area, there are only dysmorphic in the posterior area, but frontal area is already frontal area is have a symmetric shape. It means only a posterior correction will lead it. We check the volume using the imaging data, and we are measurement after measurement using the CT data. We decide the endpoint of our distraction method, and target cephalic index is 81%, and it means we lengthening the length and correction the width a little more. And we determine the osteotomy line using the simulation program like this. And also determine the range of correction area. You can see we simulation the distraction area more than 13 millimeters AP, and we need 5 millimeter lengthening the lambdoidal craniosis area. After correction, you can see the cephalic index and CVAI is a normal range. The final osteotomy line determined by the real 3D printing model, like this model, because they are a little different on the 3D image or real size. And we must design on the real printing 3D model. And using like, because their angle is a little different and the distraction is very sensitive. If there is a little different angle, it make their cranial shape more not oval shape. And the real 3D printing simulation is very important, like this case. You can see this right side. We need expansion of right side, and we select our distraction angle is like that. And this is intraoperative photo. You can see a ostectomy line, and you can see the distraction device like by simulation. Expansion, the right side, and we need more expansion in lambdocynosis area. And this is our typical design and distraction method. And today, I'll show you the bidirectional method like this brachycephalic craniosynostosis. We originally do a fronto-orbital advancement only method, but I already said to you it has some limited method, and we advance our method to like that, using the frontal bone flap and the posterior bone flap together. it is a bidirectional method. And more advanced, we are trying to remain the mid-corona bridge in there, and it make a more distraction and more expansion we can do after like this design. And last year, we performed surgery on 14 patients with craniosynostosis. Over the half of this case, we do a bidirectional method for the correction. Like this bicoronal craniosynostosis cases, you can see already a severe asymmetry is occurred on the left side of a patient. It means only frontal advance is do not correction the asymmetry of their frontal area. And we also designed the osteotomy line using the same simulation program, and we are determining the expansion area. And it is a real surgical field. We often after skin flap, and we using the like pre-designed 3D model, and we select the correction osteotomy line. And we do all surgery using a spine position. A lot of surgeons do not understand how can do the both sides using the spine position, but we are using like a horseshoe and almost end of posterior area, and we can do the surgery only a spine position. And this is osteotomy. Like a neurosurgeon do the osteotomy like that. And after that, I set a distraction device like that. And using like this device, we expansion the frontal area and the correction asymmetric of a frontal area together. And it is very one of the important point because we have a do not bridge, and it's very hard to control the frontal retrusion. And this observable fixation is most important because it fix the frontal shape very smooth, and in the after expansion there is no dismorphosion of the frontal. And sometimes this observable plate touched about the outside, and we can cover the like this observable mesh, this camouflage this observable plate. And one of the weak point of this distraction method, sometimes there are bone depression in the distraction area, and prevent depression. We also cover the distraction area using the like observable mesh on bone flap side. And after 1 month later, we almost length 2 centimeter because we need a expansion too large, and this is a final distraction result. And I will show the another cases using a bidirectional method. And first case is using the bridge method because we decide because this case need a lot of advancement and a lot of expansion, and it's the better to get a bridge is better, and using a 6 internal distraction device, we expansion almost more than 2 centimeter because it's very one of the severe case. Using the this bridge, bidirectional is more easier than just there is no bridge method. But we have a weak point like this method. The following the patient after 5 years later, there are some bony depression like that. It means there are bridge area do not grow better than the other area, and there are some depression on the frontal area if we using the bridge method. And some parent always complain like this depression. And now we are come back to just bidirectional method without the bridge, like this design. He's too older, and there are Venus is there, and we design like that because there are we want to without the bleeding, and the design like that, and do surgery like this. Method is almost same. We elevation and the frontal and posterior skin flap, and make osteotomal line, and set internal decision device almost the same position. And frontal fixation is very important to keep a frontal shape of a patient. And after removal, the distraction device, you can see expansion is too enough, and there are also the bone regeneration is very well, and there is no depression on a top side too. And this case is a metopic and rhamnoidal craniosynostosis case. This is an asymmetric case. It's more hard case better than their symmetric case because there are already fusion on frontal side too. It means if you do the surgery on your posterior side, the volume expansion is we can do the volume expansion, but we can do not correction the asymmetry. And we also design whole craniotomy, osteotomy like that, because almost after 1 year later, the bone is very harder than the younger age. If there is a little fixation in there, the bone is not movable. And we do the craniotomy line, and the real surgery is like that. Do a whole cranial osteotomy line was done, and the fixation frontal area, and the expansion the posterior area using the distraction device. And you can see after distraction, before the removal, the asymmetric is almost they are almost symmetric shape before the surgery. If some surgeon do just only correction the posterior area, it's very hard to correction the asymmetry. But using like a whole craniotomy method, you can more easier than correction the asymmetry. And this is a unicorona case. Like this severe case of unicorona case, there are already a hypergrowth in posterior area. If you do the surgery only a frontal area, there are asymmetry is remain, and it's very hard to fixation the asymmetry. And also we using the whole craniotomy and the bidirectional method. You can see like right side, there are correction asymmetric very well. Like this is same case, like same design and same simulation. And the simulation, the length of, and we determine the CI and CVAI. And after that, distraction like that. And in sagittal cases, it is a little not expansion, just we reduce the length and the expansion the width. This is also a sagittal case. Sagittal case is not a special. Just is I just show you the sagittal case how we do the surgery in a sagittal craniosynostosis cases like that. We decrease the length and expansion the width. And like this severe case, we can also using our distribution method too. Like this severe case, usually a lot of neurosurgeon do some kind of pie surgery or cranial remodeling surgery, but it have a limitation because there are bone growth is do not well in a like a severe case. But using like a distraction method, we can make enough osteogenesis, and we can make to longer time better than other patients. Like this severe case, we also like make like check the volume and make a design and determine the expansion centimeter. The two surgery are almost the same method, like frontal and posterior skin flap, and make osteotomy line and whole cranial osteotomy line, and cover the expansion area. And you can see almost over the over the 3 centimeter we can do expansion very easily and very effectively. And you already know the distraction advantage is like shorter time, operation time better than cranial remodeling. And we can also decrease the blood volume and the shorter hospital stay. In our institution, the operation time is under 2 hours, and we are under the blood loss 200 milliliter, and we are just hospital stays 5 days. And this advantage we already know, the 2 operation time and the long period of treatment, and the patient and parents compliance is very important. But other disadvantage, we can advance our method using like you already see like using the observable mesh. We can cover the flattened or hypoplastic area, and we also make incision scar more posterior area, and we only using the just the internal distribution device. We have a lot of effort to reduce the scar, because a lot of patients always thinking about their child's scar, and the scar is one of the important thing for the distribution method. And our institution do not do the endoscopic method, but I think endoscopic method have some disadvantage for the craniosynostosis, because I think only under the 6 months patient they need like endoscopic method, because inside the operation room, there are some bony attachment there. Bone is not movable. And like this case, there are sometimes there is a there is no bone growth in there. And you can see also there is some defect like that. But using the distraction method, you can make a more forehead shape is more better than just like this ostectomy method. And this is one of the complication using like removal the bone. There is no bone growth after 1 or 2 years later, and one surgeon do like cover their uh, area using like this titanium mesh. I have like that case too. Uh, this patient is have a severe craniosynostosis, and he already do pie surgery 2 or 3 months before, and after 6 or 7 months later, he already have a very small size of skull shape and skull circumstance, and we needed to expansion, and we also using like a distraction method combined with like this observable mesh, and we cover the frontal area using like this observable mesh and using a distraction method. Before the surgery, there are bulging in the frontal area because there is no bony area. And after surgery, you can see very smooth surface on the forehead using our distraction and decrease the pressure and cover the observable mesh of the frontal area like this. And this is we remove distraction remover. And you can see the bony shape, bony arrangement is very smooth after surgery. Before that, the bony spot is like this front area, but after surgery, you can see the bone shape is more smooth. Yeah. Thank you for listening my presentation, and my presentation is over. Thank you for listening.
Thank you so much, my good friend, Professor Baek, for your presentation today. And I
Thank
think we learned a lot from you, and thank you for sharing your experience with us. So now, without further ado, I'd like to go over to our panel discussion. And the first person I'd like to invite is Dr. Ike Tamada. Dr. Ike?
Yes. Dr. Beck, thank you for your very beautiful presentation. It was really informative. Thank you. And I have a few questions. The first one is, I think there are differences in cranial index depending on race, but are you performing your surgery based on normal values for Korean patients?
That's right. We designed for the Korean patient, like Asian patient, because you already know cranial index is a little different for Asian or in USA or Caucasian. But our index just focus on a Korean patient.
Oh, that's good. So you have Korean normal values.
Yes.
Okay. And my next question is, it seemed that you did not cut the front orbital bundle. How do you modify the osteotomy line if the patient present exophthalmos?
We our method we can do the surgery together because we can make osteotomy line like upper orbital line.
Yeah.
Can I wait a second? Like this this first case you can see we make a osteotomy line upper orbital area, and we advance just one block.
Uh,
And this patient is a Crouzon syndrome patient, and we need to expansion the orbital area, and we make osteotomy line like that, and we expansion orbital area together.
okay, I see. Thank you. And my last question is, without using the mid-coronal bridge, whole cranium can be mobile. So
Uh,
how do you whole
I
cranium is mobile without the middle coronal bridge? So how do you control the amount of forward and backward movement?
Before doing like that, we worry about like that because there is no fixation area, and we do not control the shape or range of their amount of this expansion. But just the fixation, the frontal area is enough because we have skin tension in there,
Yeah.
and important thing is a frontal shape. And just just a fixation frontal area, and we have a skin tension, it is enough. We can easily control their expansion without bridging.
So you don't need big advancement for the frontal area, right?
That's right. We just advance just upper frontal area only,
Yep.
not a lower side, because volume expansion, upper side is enough. We do not advance the frontal area.
Okay, thank you very much.
Thank you.
Thank you.
Thank you, Dr. Ike. And next, I'd like to invite Dr. Tin-Chen. Dr. Liu.
Hi, Professor
Hi.
Baek. I think that's a great speech because the method is very creative.
Thank you.
Especially the sagittal, I never think it can be smaller, use the distraction. So I have one questions for you. So how do you design the length of the distraction before the surgery? Do you depend on the volume or you depends on the symmetry of the patients?
First thing is the volume, and second is symmetry. But we think about both because we expansion and correction asymmetry together. This method is we can do that because we can control the each side of a length, and during the distraction, sometimes some patients have a more distraction the each side, and that time I stop this side and do this on opposite side more distraction. We can correction during the distraction season. Yeah, this method can control their asymmetry in a distraction period. Yeah.
Okay, so the parents, they will do the turning of the distraction. So do they come back to the hospital like every week?
Every week. Yeah.
Okay.
I have one accident. The distraction is broken after and after that we always set a two piece in distraction area, because if there is one device is broken, and we using the another device and the expansion, and then correction asymmetry is very difficult, like broken method, but expansion is okay.
Okay, thank you very much. So that's all of my questions. Thank you.
Thank you so much.
Thank you, Dr. Liu. And next, I'd like to invite Dr. Flores for some comments. Dr. Flores.
Professor Baek, thank you for your great presentation. I had a lot of thoughts, and I'd like to give some comments and a few questions. One is that I noticed with some of your posterior vault reconstructions, the horizontal osteotomy, inferior osteotomy was a bit on the high side, and I know that working with a neurosurgeon, how low you go is very much a negotiation. And we certainly have those in New York. But we typically put our posterior osteotomy lower than our anterior osteotomy. If we were going to compare, like we usually do our anterior posterior in stages. I think what you're doing is very interesting, and we will consider this. But typically our osteotomy is lower, and especially if you're trying to decompress posteriorly, if you were treating, let's say, trying to indirectly treat a Chiari, that would be useful. Also, I do have a concern, and you've mentioned it at the end of your presentation, with a child, let's say, who has a very severe anterior manifestation of, let's say, unicornal craniosynostosis, where it's not necessarily you have a normally shaped forehead or bandeau that just needs to be pushed forward. It is the deformity is complicated, and maybe just pushing it forward only may not be sufficient, or even in two vectors may not be sufficient. There may be some remodeling that needs to happen. So it could be a consideration, I don't know, to do that kind of reconstruction earlier if the bone is thick enough, in order to take advantage of remodeling that still may happen at an earlier age versus at a later age, closer to 1 year of age, where the bone is actually quite thick. It may not be able to remodel in the same manner. I do have some questions. How often, I didn't see this in your slide, how often have you applied this technique in patients with a syndrome, in patients with a shunt, and does shunting affect the success or complications associated with such a large volume of distraction potentially, and patients with Chiari malformation? So those three, syndrome, shunt, Chiari. So that's my first question.
Okay. Okay, thank you. Great question. Before the answer, we are very try to lower the posterior line like that. But there in spine position there are limitations better than the prone position. We already know that. But we do the craniotomy line before almost frontal, lower than frontal area, like a peak, under the peak area. And I think that is enough. And we always do the ultimate line before the peak area. And the answer, three questions, right? Answer one, sorry, I don't remember.
Chiari.
In Chiari syndrome patient, we also make a posterior craniotomy line more lower, better than the other case, and also neurosurgeon do the surgery together, and he said it is enough to control the Chiari malformation. And second answer, if there is a shunt area, we can make a design using the shunt, and we already have experience using the shunt patient, the expansion, and during the expansion we needed to control the pressure of a shunt. It needed, but we can do the distraction in a shunt patient too, like almost the same design, but we design more because because a craniotomy line is because if there is expansion, we designed there is no effect to the inside of the shunt line. And what is the first question? Sorry, first.
No, how many syndrome? What's the distribution of syndromic patients?
We also do the distraction method in the syndromic patient too, but in a corrosion patient, we are usually make osteotome line is upper orbital area, and some patients need a huge expansion. We set a lot of device better than the non-syndromic patient. It is a little different, but the distraction and design is almost same. The syndromic and non-syndromic patient too.
Thank you. And if, one other question, if it's okay. I think that your method, I think the strength of it is actually in the use of virtual surgical planning. Or you happen to be, in this case, implementing your plan through a distraction, through a distraction technique. But what you're really doing is being able to plan a much more complicated surgery using computers, right? In terms of your osteotomy design, your vector planning. So how are you determining through your computer, through your virtual surgical planning platform, where you're putting the distraction devices, how far you should be distracting each device, because it will be different and unique to each patient? And then typically when we use VSP for maybe more traditional uses of craniofacial surgery, like orthognathic surgery, when I use it at the end of the day, even when I don't use it, at the end of the day, my orthodontist gives me a grade. And sometimes I don't like that grade, but he gives me an assessment and tells me how well I did, how close I was to achieving that result. And I suspect you at least have that ability to do that with your platform. So how is this technique performing? Are there certain applications that are more reproducible? Are there certain ones that are more difficult? And because I think that's where a lot of the real interesting dialogue is, even in where you're putting in your hardware to make sure that you're creating a stable movement. So I find that part the most fascinating part. I wonder if you could expand on that, please.
It's very important question, because I always think about that simulation is very limited method, because they do not determine the angle or like little different of shape of a skull, and we always need to real 3D printing model, because using that we can determine the area of distraction and the angle of distraction, and further study, we are now to try to make a new program to determine the angle or like distraction shape, like some each distraction, and we want to make a new solution for prediction model, and we can want to education model for easier surgery, and expected like result. I know that it's very important, and it's very hard work, and you already said it's very difficult, and it's very hard to explain, like for the good result. But it depends, because you already know CT simulation is not same as a real 3D real patient skull shape, and we always determine in a real surgical field, and after craniectomy line, we set a distraction first, and distraction, and it is angle is correct, or expansion angle and expansion vector is correct. We always think about that, but after nowadays we are try to make a new software and expected model, and please wait our advance, please.
Thank you. Wonderful presentation.
Thank you so much.
Okay, and before we move on, I understand that Professor Flores, you're holding a craniofacial distraction meeting in May. Would you like to share the details with us for that?
Thank you. That's very kind, and thank you for the opportunity. First, I'd like to say that this meeting was been planned for several years, and you learn as you go, and it's interesting seeing this particular presentation and learning, as we all do continuously. I realize that even the scale of this meeting isn't enough, and I intend, I think, to repeat it, especially because there's so many new applications. Yes. But we are hosting, thank you, this craniofacial distraction meeting at NYU, New York City, May 16 and 17 of this year. We will be uniting really the international leaders for craniofacial distraction. You can see the curriculum and the faculty there. It's a 2-day course, and we will go march through every part of the craniofacial skeleton during this procedure, during this Congress. There will be a option for live stream for those of you who it may be difficult to attend all the way to New York. But this meeting, actually, as meeting of this type, hasn't been done in almost 2 decades. So we are very excited to host all of you in New York, whether live or virtually. And there is a website right there at the bottom that you can just take a picture and just to look at our curriculum. But we are very excited about this meeting, and we will be honoring Dr. McCarthy, who will also be there at the meeting. And thank you for the opportunity to promote this meeting.
Okay, thank you so much, Professor Flores, for sharing your experience with us. So next, I'd like to invite Professor Lowe for some comments.
First of all, I would like to see, I'm happy to see Dr. Flores here online. Nice to see you. And also for Dr. Baek, thank you for your presentation and introduce your destruction technique. I'm not doing cranial destruction, so my question actually is just my common sense. Okay, you mentioned that you follow Dr. Kim Yong-ok for the destruction, and Dr. Kim have been doing this for 20 years. So you must have been following the patient. I'm not sure. Can you tell us what is the growth of the cranial part after you finish destruction? For example, in the first year, you finish destruction and then you continue to see the patient even maybe become teenager or even adult. What is the scalp has become? Is it still continue to be a normal shape, or you have a different observation?
Yeah, I observation after 10 or 15 year later patient too, but their cranial circumstances so normally gross after surgery, but there is some little bone thinning area and bone defect is there are already there are some patient there is some defect in a teenager area too. I think is that do not appear permanently, but the circumstance the growth is almost become normal after surgery.
Mm. And also, you mentioned that you use virtual design before the destruction, and you have a normal Korean scar age match. So when in your design, your destruction is to so-called the age shape, normal shape and size, or do you do over destruction compared to the non-synostosis side?
You mean the
your correction, you destruct, for example, anterior part, unilateral forehead, you do overcorrection, posterior part overcorrection, or normal correction?
we do the overcorrection because but little overcorrection better than the their own age skull shape, because the after surgery, you already know there is some scar and other some growth is better than normal area, and we expansion little more the normal shape. We over expansion. I think one of the important thing is the over expansion. Yeah.
Okay.
But
Yeah, thank you very much.
forehead shape is very important, because we always keep the forehead and we just expansion or a frontal area like that.
Yeah, thank you. Thank you for your wonderful job, and also a continuation of your so-called the destruction practice. Please say hello to Professor Kim Yong-ok. Thank you.
Thank you so much. Yeah.
Okay, and I think Dr. Zhou has a question that he would like to ask the panels. So Professor Zhou.
Yeah, thank you. Excellent presentation, Professor Baek. And based on Professor Flores' the questions, I would like to ask all our panels about you have any experience to use the VSP for the design for the synostosis patient, Professor EK and Professor Chen. What is your experience, or what the scenario you will design, or what the scenario you could not design? Thank you.
Me? I have no experience in virtual surgical planning. I just see the 3D CT figure and make the 3D model and plan the cutting line using the pencil. That's all. So the surgical planning is in my head.
Okay. Yeah, because my understanding is we can use the VSP for facial trauma revision surgery, navigation, and we can design for two-jaw surgery for already mature skeleton part. However, in the infant within the 1 year of age or above the 1 year of age, I actually have no idea what the velocity and the extent of the cranial valve growth, and you can make the design, and what is your basis for that. But I know Professor Lu has some experience. Yeah, Chen, please.
So I think we have a normal skull model. So based on the patient's, we will expand the skull model by the eye. Like if the patient has a bigger eye, then the patient has a bigger skull. But maybe there's some difference on the different age of the patients. But we just based on a normal skull model.
Okay, thank you. So I would like to ask Dr. Flores about your experience in NIU as well. Thank you.
Sure. I use quite a bit of VSP in jaw, and particularly complex jaw reconstruction. For cranial reconstruction, I have not used it, and I may use it in the future. In the United States, VSP is widely available. However, it is very expensive, and we, as surgeons, we are protected, or that those costs are hidden from us, probably for a good reason. I have a certain opinion about VSP, which is that at least in jaw surgery in the United States, it's overutilized, because it does make things convenient, but that doesn't necessarily mean it should be used. I use VSP for cases in which I feel like I will get a better result, not an easier result, not a faster result, but a better result because of the complexity of the case. Like an adult with rather severe facial scoliosis from craniofacial microsomia, I think 10 in a row, I will get a much better result with VSP. So when I think about when I'm going to use this technology, I think about will I be able to do a better job compared to what I'll be able to do with traditional methods. And I would say that certainly not, there are a number of my cranial reconstructions that do not look perfect. But the question is, will implementing VSP, give me a better result? I know that some people have used VSP to break the cranial segments into multiple pieces and design something that will look better. And this is another implementation. But I do think that what makes cranial reconstruction difficult, and it was implied already, is that the child is growing. And that's the one thing we cannot change. We're dealing with forces that we cannot fully predict, or really, and that we don't understand yet. When someone is fully grown and they're not going to develop anymore, it's easier to plan a surgery. So for me, I've been kind of waiting on the side and in an observation phase with regards to this technology as applied to the cranium.
Okay, thank you. Thank you, Floris. Okay, so Junior, proceed. Thank you.
Okay, and next we like to go on and proceed with our Q&A session. So our first question is from Dr. Honda. The question is, can you tell us a little bit more about the absorbable mesh that you use to cover up the plate? What kind of material do you use?
There is it's a hybrid mesh using observable polymer polycaprolactone combined collagen mesh. That observable mesh is that kind of mesh. I made that type of a mesh in Korea, and I using that hybrid mesh cover the cranial defect or some dimpling area. It is it is the hybrid type of mesh using polymer combined the collagen.
And
It
you
is
use that for all the cases, or only
almost
specific?
almost case I use that because prevent dimpling of distraction area and camouflage some observable plate, because some patient have a complaint to they touch the observable plate on a skull area.
Okay, and then the next question is actually from me, and I just want to ask you a little bit about your procedure. Like, is there an age restriction that you perform the surgery for?
Pardon?
Is there an age restriction that you perform this surgery for? Like from what like how many months old till like how many years old do you perform the surgery?
It is usually our patient is under the 2 years, but some late patient come there the 3 age or 4 age. We do the surgery, but we do not expect the growth of a brain. But just we do the surgery because the patient parents want to do the surgery, and their dysmorphism is very severe, and just correction asymmetry, and we expect the brain growth. But after maybe 3 years later, they're not good. Their growth.
Okay, so because the reason why I'm asking is because I saw during your presentation you share a case where the patient was 3 years old. So I was wondering if does that mean that, you know, for patients who are older than perhaps like your criteria of 2 years old, then you would beforehand you would explain to the parents that, you know, maybe the you can correct the aesthetic part of the part of the cranium, but then you can't really help them to, you know, expand their brain in that aspect. I wonder if this is the
if a child is a normal growth, we do not surgery just only the aesthetic, but together their growth retardation together, we just do surgery, expect the like brain growth.
Okay. Thank you so much. Thank you once again for coming on to ICC and sharing your experience with us. And I
Yeah.
guess it's time for a group photo, right?
Yes, yes. Before the group photos, I have last one question. Is that the hardware of the distraction devices in Korea that is under insurance coverage, or patients should have self-pay for that?
We covered the full device insurance, and after
Oh,
5,
okay.
only 4.
Okay. Only 4. But I saw lots of you all almost in average is 4
Yeah.
devices over for your patients,
Over
right?
4. Yeah, over. I usually
Very-
6 or 7.
Okay, very nice. And thank you, Professor Baek, and your excellent experience to treating those patients with synostosis. And I would like to end up with the group photo and invite all our participants tonight. Yeah. And before the group photo, I would like to remind all our participants again about NYU's distraction course and held by Professor Roberto Flores again. That course is not only be held by in-person courses, and you can have the online course as well, right, Flores? And Professor Robert enrolled last of the professors, yeah, Makasi, yeah, and like Harper's, Bartlett, yeah, they are all the giant of the distraction all over the world to give us all their experience. So welcome over, you can reach this coast too. Okay, I would like to invite my friend, and you can turn on your screen to show you a smile with me. Thank you. Always, I would like I will count to 3, and then you can give a smile, give me a small heart anyway. It's okay. Okay, 1, 2, cheese. Yeah. Thank you very much. Okay, so
Much.
thank you, Professor Baek, for your presentation, and thank you, Professor EK Tamada from Tokyo. Thank you, Tintin from Taiwan, and a special thank you for Flores to coming to ICC the first time. And good morning again. Thank you for your sharing your experience, and I hope to see you. Our next ICC presentation will be held on the February 25th, and Professor Bologno from Thailand will give us a special lecture to talking about head and neck reconstruction by various the microsurgical technique. And have a good night, and have a good evening, and have a good morning too for all of you. See you next time, and
See you next
thank
time.
you. Bye-bye.
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 Thank you, Dr. Bach.
Thank you.
Thank
Again.
you.
See you soon.
Thank you, Dr. Baek. Thank you,
Thank you.
Roberto. Thank you, EK.
Thank you. Great
Thank
presentation.
you, Junior.
Thank you.
Thank
Yep.
you. Yeah, keep in touch. Okay, bye-bye.
Thank you.
Bye. Bye.
Bye.